Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Good day for all the audience all over the world. And I would like to thank the organizing committee for inviting me. As well, I would like to extend my utter gratefulness for the genetic team at Latifa Women and Children Hospital, led by Dr. Fathi, for giving me the chance to see the Down syndrome children and to get experienced in handling them. And also, I would like to say thank you so much for each Down syndrome who visited the clinic and he drew a smile on my face. And in the next 20 minutes, I'm going to talk about our audit at Latifa Women and Children Hospital, performance and more realization for better outcome. The idea in this audit was to emphasize that constant follow-ups of Down syndrome in the outpatient clinics remains a cornerstone for providing them with the appropriate health service and early detection of comorbidity, targeting a better outcome and striving to an independent, healthy individual. So in this study, we audited the appropriate screening and referral of children with Down syndrome in comparison with the international guidelines. And this was accomplished with main objectives of identifying the number of children with Down syndrome referred to the genetic clinic at Latifa Hospital, where the service is basically provided. In addition, to identify the number of children with chronic diseases, whether they had appropriate investigation and whether they were provided with the health education and whether they were knowing exactly what type of surveillance they needed to do. The method was retrospective, but before going to the method, I would like to show you our guidelines that had been uploaded in the facility system, and it was accessible by all the clinics, by all the doctors in the clinics, whether they were in the primary health care, whether they were in Dubai Hospital, Latifa Hospital, or any other hospital. So they can easily access these guidelines and they can extract the information of the appropriate investigations and surveillance needed according to the age. So the method basically was retrospective, and the data was extracted from the genetic records and the electronic medical record system. Population studied were all patients with Down syndrome seen in the genetic clinic in the period from January 2015 up to December 2017. The exclusion criteria were patients that had been not regularly followed up. And I would like to say also that the data did not include the antenatal diagnosis. The results were analyzed manually in an Excel sheet. And in the next slides, you can see that the majority in this slide, the total number of patients were 171, as I said previously. And the age distribution at the time of the audit was mainly children between 1 and 5 years. Almost 50% of the children were between 1 and 5 years. Here, I would like to say that the genetic clinic, although the studied group was from 0 to 13, but the genetic clinic, they continue to see patients with Down syndrome beyond that age. These are the abbreviation I had used in this presentation. Y means age-appropriate investigations and referral to specialized clinics. N, not appropriately investigated and not referred. I, inappropriate timing. And NA, not applicable for the age. This slide will show the referring clinics: emergency, pediatric surgery, general pediatrics, and so forth. So most of the patients had been referred from the NICU, like 66, or 38.59% had been referred from the NICU and the postnatal ward. And the least number was from the PHC. This slide will show the average time lag between the referral and time when they had been first seen in the genetic clinic. And that was calculated to be around 3.4 months, which seems to be a little bit a lengthy time. And I will speak about that in a minute at the end of my presentation. The number of Down syndrome associated with chronic diseases, they followed the international figures. The cardiac anomalies constitute 64%, and the significant developmental delay was in 55% of the patients. This is the same slide with the distribution of the developmental delay, feeding difficulty, congenital heart disease, hypothyroidism, and so forth. I just would like to say that I mean by others like strabismus, overweight, cow milk allergy, any other comorbidities that have been recorded in the 171 patients, like suspected celiac, epilepsy, alopecia areata, myeloproliferative disorders. And most of the patients, they underwent karyotyping before reaching the Down syndrome clinic. Only few patients, they reached the Down syndrome clinic, and the referral was only upon their clinical features. Here, I would like to say that the data for the health education was basically extracted from the genetic clinic. And I would like to say proudly that all the patients, almost all the patients, 100% of the patients were counseled fully, and the explanation was delivered verbally, plus printed materials about all the education, about all the surveillance needed. The communication was tailored according to the parents' level of education, and also sometimes according to their acceptance to hear in that clinic, with documentation of any information needed to be delivered in the consecutive clinic or needed to be repeated again. Even sometimes in the presence of a translator, because most of the patients seen in Dubai are from multicultural background and multi-nationality. Then in this pie chart, you can see that the investigations, the FBC, the compliance was very good for the FBC and the thyroid function test. Most of the patients, the thyroid function test and the FBC were done to them prior to coming to the genetic clinic. The celiac screen, there was a problem in the celiac screen, as some of the celiac had been done in inappropriate time. For example, they had been done at birth, so that time was really not justified time to do the celiac screen, and it doesn't follow the guidelines. Cervical x-rays, as per the guideline, it should be done between 3 and 4 years of age, unless there was a medical indication prior to that. So we found that 45% of the children, they had the cervical x-rays done to them. In this pie chart, you can see that there was excellent compliance with echocardiography. And most of the patients, they reached the clinic, they had already echo being done to them. Coming to the appropriate referral, starting by the hearing assessment, unfortunately, hearing assessment and ophthalmology, the compliance were the least, as well as the referral to the physical rehabilitation. So physical rehabilitation, hearing assessment, and ophthalmology referral, all of them the lowest from all clinics. So there was no compliance, or there was no concentration on doing those from all the clinics. On analyzing the clinics, individualized clinics for their compliance, like from the PHC, as you can see, also the echo had been done. So echo was always having the best compliance, and you can see that the least was the physical rehabilitation. Also, this is patient referred from the emergency. The emergency also concentrated on doing the echo and the FBC thyroid function, but for the physical rehabilitation and others, there was least compliance. Referral from the pediatric surgery, the same pattern, and referral from the postnatal and the NICU. Also, they followed all of them. You can see just they followed the same pattern, with the best being the echocardiography. So, coming to the conclusion and the recommendation, we found that appropriate age investigations were variable among the referring clinics, with almost excellent to average compliance for echo, FBC, and thyroid function test. That was ranging from 100% to 66%. And it was poor for the tissue transglutaminase or the celiac screening, cervical X-ray, referral to ophthalmology, and hearing and physical rehabilitation clinic, where all of them were below 50% from all referring clinics. Also, we concluded that the guideline recommend referral to ophthalmology, hearing and balance, and physical rehabilitation that should be done immediately at birth or at the time of the first visit. The other conclusion that the average time for the patient seen in the in the genetic clinic was 3.4 months, and this was like was not fitting with the early intervention, as the early intervention is crucial for better outcome. So at that point, the recommendation at that time was the referring clinics were recommended continuing following the Down syndrome patient with the referral to the international guidelines and the local guidelines that had been uploaded in the system. And the last recommendation was establishment of the Down syndrome clinic. I would like to say that thankful that we managed to achieve this target, and in the next consecutive years we had the Down syndrome clinic, and it was a special clinic only seeing like 5 to 7 patients of Down syndrome per day, twice per week, with a target of having a multidisciplinary clinic at the same day. And what I mean by multidisciplinary clinic, that all the facilities like the ophthalmology, the ENT, and the psychiatry, the psychologist, all to be at the same place in a well-established Down syndrome clinic. With this recommendation, I come to the end of my presentation. Here are my references, and thank you so much for giving me this chance. Any questions?